delighted to say joined for one of our latest podcast sessions here, Top Doctors UK, by esteemed consultant orthopaedic surgeon, Mr. Matthew Oakley. And we're going to discuss knee replacements today, and in particular, personalised knee replacements and 3D imaging and robotic assisted surgery with this approach. So, Mr. Oakley, thanks so much for your time. And if you'd like to maybe tell viewers and patients about your medical background.
I'm Matthew Oakley. I grew up in the Midlands of England and Shropshire and went to Oakley University in Glasgow and did my highest surgical training in the northeast of England with a brief spell over in Denver, Colorado, and in Birmingham. My specialty is joint replacement, both hips and knees. And over the last 23 years or so as a consultant, my aim is to produce the best possible results of both knee and hip replacement. That has driven me towards personalisation of the fitting of knee replacements to improve the outcome.
Fantastic, Mr. Oakley. Thank you for the background. And then I suppose question number one for our topic this morning. What does a personalised knee replacement actually mean? And how does this approach differ from a standard knee replacement?
So that's a very good question. Everybody's knee is slightly different. The knee is made up of three joints, really. The joint between the patella and the femur, and the medial femoral tibial and the lateral femoral tibial. And every patient has a slightly different proportion of each one. When you've looked at enough knees, you start to realise they're like fingerprints. Everyone is the same. Knee replacement is one of the best treatments in modern medicine in terms of quality of life years added. It's perhaps beaten by cataract surgery and hip replacement. Hip replacement, the vast majority of patients are delighted and they say the joint feels normal. But if you look at knee replacement, probably 80%. Now that's pretty good. In most interventions, to get 80% success, which lasts for, on average, 20 to 30 years, has to be regarded as a success. But once you practice for a long time in one area, you start to look at the 20% who aren't quite so happy. Nothing's gone wrong, but they're just not quite so happy. And that leads you to try and see how you can improve matters. The way I was trained 20 odd years ago, and I have to say, the way the majority of surgeons still do knee replacement in the UK, is everybody's cut the same. Everybody's cut with 5 or 6 degrees valgus cut at the femur, a little into external rotation of about 3 degrees, etc. So everybody has the same set of numbers. Now, for the group in the middle, those numbers are quite good. But every biological system has variability. And those at the edge of the variability, they're much less likely to be happy with those standard numbers. And that's why I got interested in personalisation of making your surgery fit the patient, rather than put the knee in and then try and make the patient fit the surgery. Does that answer your question?
Fantastic answer, Mr. Oakley. Absolutely. And it leads us nicely then on to question two. Can a customised or personalised knee replacement help you recover faster from, for example, traditional knee replacements?
So there's several elements to that. If you put the patient's joint line back exactly where their joint line should have been before they had the disease, that means that the patient will have ligaments which are just as tight, fully extended, as fully bent, so they won't be fighting to gain range of motion afterwards. They'll have less pain and they'll recover quicker, and the knee will feel better in the long term. Now, you can accomplish that by various means, but yes, customization of the fitment to the patient definitely improves early outcomes, but probably more importantly, late outcomes.
Fantastic. And that's reassuring to know for patients considering this approach. So that's great. And then I suppose touching on 3D imaging and robotic assisted surgery and even patient specific implants, can these all improve knee replacement outcomes?
So every one of these are tools which enable the surgeon to more accurately get to their philosophy. Robotic surgery in itself won't help at all unless you use the robotic carefully in order to obtain a more customized fitment to the patient's knee. Customized implants. Customized implants, the conformists. I've had some brilliant results with the conformists. The conformists where they actually make a knee to fit you. You take a scan, the scan is digitized, they make a mold from the scan, and an implant is cast which fits your femur. This enables you to get restoration of the joint surfaces. It enables you to cover the bone exactly, and you can get more natural motion. But if you put it in wrong, it's still not going to get a good result. And you've got to understand what you're trying to correct. I found the conformist works best in patients' knees which aren't completely destroyed. When they've got more deformity, then it doesn't work quite so well. So there's a group of patients there where the customized knee, as in made to fit the patient's anatomy now, doesn't work as well as I can make a standard knee fit, but customizing where I'm placing it exactly on the bone. Robotic surgery is lovely in that once you tell it to cut at so many degrees, it cuts at so many degrees within 1 mil, within 1 degree. Now, that's slightly better than a good surgeon can do, but it doesn't help if you cut in the wrong place. And that's the understanding of the philosophy to what you're trying to aim to try and restore the patient's anatomy. So I don't think any of those three are the panacea. They're all tools which enable a surgeon who has an interest in trying to personalize the fitment of the knee to the patient will get good results. And I use all three.
Fantastic. That's a very detailed approach, and it's good for patients to be aware that it's, aware of the advantages of these three approaches. But like you say, it kind of is, all-inclusive approach. It's not just relying on that. So that's great to know. And then question,
But just come in. It's also
absolutely,
probably
Mr.
fair.
Oakley.
It's also probably fair to say that the robot is not a robot. It doesn't walk into the room and do the surgery. The robot is more for those with a mechanical background. It's more a CNC lathe. You type in the digits that you want it to cut, it cuts there. Now the problem with that is that it's on a biological system, so it's not like making an item for a car where each one of that model will be the same. A lot of knee replacements is like hand fitting panels to a handmade car, because we're all handmade. We're not made by robots. So there's a misunderstanding of exactly what the robot is.
That's very good to clarify. Absolutely, Mr. Oakley. Because especially nowadays, it's only going to be more prevalent, so it's great that people can actually know that and have, their expectations can be, healthy. Great stuff. So our next one then, is a personalized knee replacement suitable for every patient?
So I've touched on that already. Personalised care is always suitable for every patient. That may not just be the knee replacement, but that may include the anaesthetic, the post-op recovery, the analgesia afterwards, the physio. This is all personalised care, and everybody benefits from that. I believe that everybody benefits from personalising the alignment of their knee replacement to what their natural alignment should be, rather than putting everybody back the same. But as I touched on before, I found in more severely damaged knees, the conformists, where we're making a knee replacement to fit, due to restrictions in their planning process, isn't quite as good, but it's very good for patients with moderate deformity. The robotic surgery has advantages and disadvantages. You trade some advantages for some disadvantages. So one of the things about the robotic surgery is the best robot at the moment is the Mako, made for striker knees, because it stops the blade cutting outside where the edge of the bone, so it will protect against that. It's by far, but it's tied to an implant which isn't quite as constrained as something like the Attune. So if I've got a high demand patient who wants to get back to playing tennis, perhaps skiing, I think they probably do better with a slightly more constrained implant, some sort of like a tune rotating platform, which doesn't fit with the robot. So while I've got access to the robot, I don't use a robot for every case.
Fantastic, Mr. Oakley. Very detailed answer there, and leads us nicely then to question 5. Can personalizing the alignment and positioning of a knee implant reduce the pain and improve long-term knee function?
So the short answer is yes. I'm convinced it makes a huge difference. And if you look at the data we have from the patient recorded outcome measures, my patients get more improvement than average compared with other patients in the UK. In terms of survivorship, knee replacements already lasting well. Knee replacements last a bit better than hips. They say the average knee replacement put in 24 years ago is still going strong. So we've got a system which works well if you're 60 and older. But what we've got to try and do is make it better for everybody. And to make it better for everybody, then you need to personalize to fit the patients.
Great stuff. And then question number 6 today for your information, Mr. Oakley. How exactly do orthopedic and specialist knee surgeons like yourself decide which personalized approach is best for each patient's anatomy and certain lifestyle?
Mm. So the first thing is you've got to get to know the patient. You've got to listen what their problems are, but also you've got to listen what their expectations are. If you come to see me and say, I want a knee replacement to return to play rugby, I will tell you those two are incompatible. I still can't give you a knee that you had when you were 17. And anybody who says they can, I'm afraid he's telling you a fib. So you've got to align what is possible and what the patient wants. And that's important. You have to get that alignment by discussing with the patient at the beginning. A good knee replacement should let you walk as far as you like, let you cycle. You can play social tennis, but you're not diving to the floor for get the ball back over the net. If you ski well, you should be able to ski, but you shouldn't learn to ski. You have to accept they're still not as good as the one that God gave you. So getting to know the patient first of all. Then we look at the x-rays. What have they got? Does their knee look like it's got normal alignment, or are they a patient with more valgus? Are they slightly knock-kneed or slightly bow-legged? How much of that is their deformity and how from their disease, and how much of it is what they were born with? What is their shape? And looking at all these things and aiming, then you can choose your best strategy to give them what they wish. And that may be conformist, custom made. That may be a standard knee with a good constraint, like a tune RPPS, or it may be a striker knee using the Mako. But the vast majority of patients, by choosing one of these, we can get them there.
Fantastic, Mr. Oakley. And then our last question then for today's podcast. Will personalised knee replacements become the new standard of care, or are there still challenges with regards to the widespread adoption of this?
I think they will be. And there has been a great upsurge in personalisation of placements. And that has been led to some extent by the robotic surgery. Because the robots do show you the figures exactly. And if you've never, it gives surgeons the confidence to start changing their numbers. Now, I was personalising knee replacements long before the robot came. So to some extent, the robot is just an addition into my practice. But for some people, it has been a change of practice. It also depends on the robot. The Mako is the robot which looks most like a robot. There are all the other major companies have systems. I've done bits with all of them, and they all are not quite as good as the Mako, I believe, at present, but still be Confluent design. The other thing about robotic surgery is almost certainly it will become the new norm, because if you've never done surgery without the robot, you'd feel naked. without using it. A surgeon who comes up who's trained now, who's never done it using jigs and the steady hand, will struggle to cope again without a robot. So I think it probably will be the new norm. We're in a changeover period, and some of that's beneficial, some of it's not. The surgery takes longer. There's a new set of complications which can occur with the robot due to pin site problems. And I say, it is just a tool. It is not a miracle.
Well, that's a lovely answer, Mr. Oakley. Very realistic, and it was a lovely way to finish our podcast for this morning. So thank you once again for your time, Mr. Oakley.
No, thank you, Connor. Thank you for giving me the opportunity.
Thank you, and have a lovely rest of the day, Mr. Oakley.
Thank you. Bye-bye.
Bye bye.